Good evening, everybody. Tonight is the 27th day of January, 2022. This is Smiles in the Sun, back to business, session 58. Hard to believe, but session 58. Joining us tonight is Kendra Sellers. She is a registered dental hygienist and actually is the coach, writer, and presenter for us tonight, but runs a company called TIPS, Tandem in Practice Solution. And she is based just in the Chicagoland area. She's been in the dental industry for over 28 years and is considered one of the most passionate and successful coaches any practice could partner with. She is viewed as a predominant educator in the field of oral systemic health, intertwined with dental medical billing. And she is a brilliant presenter that will share with us some interesting ways in which dental procedures can be billed medically. And if you think you know it all, you have a lot to learn tonight. Kendra, thank you for joining us, and I'm going to pass the floor over to you.
All right. Sounds good. Thank you for that. And thank you, Dr. Glazer, for inviting me to be on tonight. I love opportunities like this to get in front of dental folks that, you know, obviously you're here for a reason and have the same passions that I do if you're continuing to be on meetings at this time of the evening, because I know that you've had a busy day, and, you know, to add this to your day is extra. So thank you for the opportunity, and thank you all for joining. You know, you brought up a little bit, I am a hygienist. That is where I've always been. Due to a ski accident, as you were talking about skiing, I was taken out of my clinical career due to a ski accident. And now I'm kind of on the flip side, and I've landed in dental medical billing. And I really got into this because I had attended several meetings by Dr. Chris Ferrugia down in Florida. And I thought, wow, this is really cool. I can actually be that advocate to patients in a different way. Because I loved being an advocate for my patients clinically. And not, you know, I was missing that. So I started TIPS, and here I am today. I've seen a lot of different things in the industry as far as dental medical billing. And for me, I saw some ethical concerns, which made me only more passionate about wanting to help practices with this process. I also saw practices going to seminars, learning about medical billing, but then not knowing how to actually take that information and implement it into your practice. Because we can attend CEs all day, but whether or not we can actually bring it back to our team and get it running is a whole different process. So that's how TIPS started, was I saw the gap in this. I saw the gap as being implementation into the practice. How do we do this, and what do we do? So that's really my disclosure. I mean, that's my company, it's my baby. That's what I do to help practices grow, and we collaborate together with medicine to get this successful. So I really want to show you what are the opportunities with dental medical billing. There's a ton of them, a lot more than most practices realize. I don't know if you've tried medical billing. I get a lot of practices that have tried and not been successful. And I want to review some of the successes that we've had, as well as all the opportunities that you have. I think you'll be surprised at what that is, and how do we close this gap so that we can be paid and be recognized as truly medical providers as we are. So I'm jumping right in. Evaluations. Evaluations are a big one that I see. You do a ton of evaluations in your practice. Those are billable to medical. Your radiology, lateral ceph, CT, PANS are all billable to medical. Surgical procedures, TMJ, seeing a lot of TMJ right now. Seems like people are really stressed out with with COVID, and we're seeing a lot more Botox and things like that being done because people are just cranking on their jaw joints. Sleep apnea, trauma typically trumps everything. Other things that we can bill for, doing a lot with frenectomies with all the lasers that are being used for, the Celea laser. We're seeing a lot of frenectomies as well as other procedures. Botox, as I had mentioned, biopsies, fluoride varnishes, advanced oral cancer screening if you're using a Velscope or oral ID, things like that. Also systemic conditions. A patient that has a systemic condition that is affecting the oral cavity. Thinking about medicine in general, a lot of dental practices want to just submit for this or that. When we go to an MD, we see them for an evaluation that's paid for. Our diagnostics are paid for, and then the treatment is paid for. So we need to think more along the lines of medicine and how do we integrate this into our practice. So it's not just about the CT, but what is the evaluation that's going into that CT, and then the treatment that is a follow-up. So we need to think about diagnostics and treatment. I really, if you don't get anything out of this presentation tonight, I really want you to start looking at dental insurance as a supplemental benefit. It truly is a benefit plan. It's not an insurance policy, and it comes with a lot of limitations, exclusions, and restrictions, frequency issues. And of course, most patients at the tops probably have about $2,000 in benefits that they can use a year, which is very, very minimal. It doesn't buy much these days. And those allowances haven't changed since the 1960s, even though our costs have went up. So we really want to look at dental insurance as more of a supplemental benefit plan versus a true insurance policy. I'm going to bring up deductible right away because a lot of people, one of the very first questions I get asked about is deductible. Well, we see, people have such high deductible plans. That is true, but that doesn't mean that every code is going to go towards deductible. We can't predict that. When you call an insurance company and ask about some of these things, they're always going to tell you after deductible is met, this is how we'll pay on that code. The person on the other side of the phone really doesn't know if that particular code is going to go towards deductible or not. And I have some examples of that. This patient actually, this is a sleep claim, and we billed out on July 17th. We billed out a tomographic study, an orthopanogram, an evaluation, pharyngometer, lateral ceph, and rhinometer. Nothing went towards deductible. Some things went towards coinsurance. Everything was paid. So these are things that are commonly not being paid when coming to the diagnostics of sleep apnea, but they are paid.
Kendra,
Yeah, go ahead.
We have a question from Frank. Unmute, Frank.
Hey, Kendra, sorry. My question is, here in New York now, 99% of the medical insurance plans no longer have out-of-network benefits. Most people, myself included, have in-network because, the network is huge, in New York, whether it's Oxford or Blue Cross or Aetna. Basically, the network covers all the hospitals, all the doctors and whatever, and everybody's in network. So now, as an out-of-network provider, there is no coverage. So it's not a deductible issue. It's an out-of-network provider coverage issue. The days of having an in and out-of-network benefits are cost prohibitive here in New York area. So everybody's got in-network coverage only. And obviously, if you travel out of state, you do have out-of-network because you fall under their emergency category and you'll get coverage whether you're here or overseas. But in your area here, I don't know anybody that's got out-of-network coverage much anymore. I mean, you can ask the group, but
they don't have a PPO plan?
No, in New York City, in New York State, PPO plans have gone by the wayside. So the average person who has health insurance through their employer what I provide to my staff, what banks are providing to their staff, what, big Wall Street companies, they're basically, they don't have PPO plans. Everybody's in network because the networks are so large that there's no reason to give in out of network. The networks are pretty much all inclusive in New York City area. You can go to, God forbid, you have Cancer Memorial, Sloan Kettering, Columbia, or you can go to the local city hospital. Everybody's in the network. So there's basically, it's a monopoly. You have your Oxford, your Aetnas, your Blue Crosses, your Guardians, and they're all the big boys, and they all pretty much provide in network. And the difference that the employer gets to pick is your deductible / co-insurance coverage, and that'll determine, the premium. I mean, somebody can correct me if I'm wrong, but, that's what I see here in New York City.
So, I mean, I'm in New Jersey right now working with the team, and we're seeing payments with those types of plans. Now, you can also consider going in network with those plans. Some of them will allow dentists to go in, some will not.
No, the paperwork, I tried that
Aetna
years
will
ago. It's just crazy because it opens you up to audits. You use them once and then they're auditing everything and making your life difficult. It just doesn't make sense at all. Back in the day, I used to do medical billing 20 years ago when people had PPO plans, but nobody does now. So that's why I'm saying I don't know what the workaround is.
I mean, going in network would be one. The other on cases, especially if they don't allow a dentist in network on larger cases, if you're looking at surgical type plans, would be getting a gap exception for that one time of treatment. That would be the other thing, especially when they're not allowing a dentist in network.
Yeah.
But I know, I have lots of other states that I work with, and as an out-of-network provider, they're being paid. I'm in Illinois, and Blue Cross doesn't allow dentists in network. Aetna does not allow dentists in network, but we're still seeing great payments. So it may just be your region, and you may have to just be more selective. Like Aetna in general, Aetna pays dentists. We have a lot of Aetna by us. The client I'm working with in New Jersey here, they've got Aetna, and we're getting payments as well. So again, it's going to depend on the policy. I don't know about your Blue Cross. Now, you might be hung up a little bit with United Healthcare with the Oxford plan. I'm not sure. But
Yeah.
Blue Cross in general will pay an out-of-network provider. But Blue Cross is its own animal in every state. So,
Yes, it is. It is. It depends if it's an
that would-
HMO, an EPO, a PPO. There's a lot of different plans for Blue Cross.
Yeah. So, I mean, the only other workaround to that would be to try to go in network. And again, some will allow you in, some will not.
Okay.
And Blue Cross is the biggest animal in almost every state. And, again, some will allow you in network and some will not. I also see in some areas where if you're in network on the dental side, you're automatically in network on the medical side. So it's very different in every state for Blue Cross.
Okay, thank you. I didn't mean to complicate the conversation here. Sorry.
No, that's okay. That's okay. I would say credentialing has gotten, a little bit easier. They're getting more used to dentists being wanting to go in network and providing surgical procedures. So if that's something that you want to consider even trying, I would say you may want to use a company that's all they do is credentialing, because it's time consuming to try to do that on your own. So here's that part of that deductible conversation with sleep apnea and the diagnostics. The same exact date of service for the home sleep study. Now you see a deductible applied, no co-insurance, no co-payments. So that's what I mean. It depends on the procedure code, how it will apply, whether it applies or not to deductible or co-insurance or co-pays. But to say that every single code goes towards deductible is absolutely not right. I've actually seen sleep appliances get covered without any deductible at all. It's going to depend on the quality of the policy. There's great plans in medical, just as there are in dental, as well as bad plans on both sides. So it's going to come down to the quality of the policy. I think it's really important for us to start shifting our mindset and start thinking about medical billing in a different light. If you look back even into the 1910s, the Mail brothers were very instrumental in bringing this whole gateway to oral health and systemic health. Yet when we look at dentistry, we're completely a separate entity from the medical community. And it doesn't make any sense. With all that we know with oral systemic health, it no longer makes sense for us to be divided. And why we even truly have two different code sets is beyond me anymore. I don't understand that. And maybe one day we'll have, we'll all be married in one. I'm not sure, but I don't know if I'll see that in my lifetime. But if we look at if the blood's coming out, the bacteria is streaming through the rest of the body, and within 1 minute we know that that bacteria is reaching all of our organs, our lungs, our heart, our capillaries. It doesn't make any sense anymore that we are so separated from our medical community and that we're thought of as something lesser or not as important as an MD. I see that all the time, and MDs don't understand really the importance that we play in overall systemic health. And I think it's time to really change that. I think COVID has brought a lot more attention to that as well. We also know that within 30 days after a dental procedure, a patient can have a vascular event. So again, what we do does affect the rest of the body, and we just have to start making that shift that we are medical professionals. You guys are not just dentists. I'm not just a hygienist. We're so far beyond that anymore. We need to really look at ourselves as medical specialties. As long as we are doing a full head and neck evaluation, the maxillofacial area is our wheelhouse. That makes us a medical specialist. So I'd love for us, and I'd love for dentistry in general to start thinking that we are a true specialist. We're no different than an ENT. They have their specialty, we have ours. And it's not just about counting teeth any longer. I get asked a lot, are you sure that we can bill to medical? And we can. They can't discriminate against our provider type. And this is what's frustrating with me as far as credentialing and things like that. The fact that they're discriminating against our provider type and not allowing dentists in network doesn't make any sense to me. But when it comes to payments, and there are a few states, I see it in Michigan, they do discriminate against our provider type, and they will not pay anybody but an oral surgeon. And I've tried to fight that, but it's little old me trying to fight a big entity against this statute. And that's, I need dental professionals, and I need, state boards going to bat for this. But technically, they can't not pay us for the same procedure that they would pay an MD. When we look at this statute. So yes, we can bill to medical. In fact, we can bill to medical and dental up to our full fee to try to recoup our full fee. When we look at the biggest definition that we need to key into is medical necessity. And medical necessity just means that we are preventing, diagnosing, we're describing illness, injury, conditions, diseases, symptoms via diagnosis codes. That's the biggest gap between medical and dental, is that we never have to establish medical necessity to get paid on a dental claim. On a medical claim, we need to. And the way that we do that is really keying into keywords of pain. Does the patient do they have cancer, trauma? Do they have impaired function, sleep? Do they have sleep disordered breathing or defects in their nasal cavity? Is there bone atrophy? Do they have xerostomia? We need to take these terms and we need to put them into diagnosis codes to show them this is why we're doing what we're doing. This is why we did this procedure. The patient was in pain. They had an infection and we treated it. On a dental claim form, you never have to put a diagnosis code down. So the biggest gap that I see in all of this is understanding diagnosis codes and procedure codes, because it's a different code set than what we use in dentistry. It's not that tricky. There's a lot of overlap, and there's a lot of repeat. We do a lot of the same procedures every single day. But when we look at diagnosis codes, there's over 72,000 diagnosis codes that translate the medical terminology of pain, say, translates into a diagnosis code pointing to why the patient came in for an evaluation. So we need to start understanding what diagnosis codes are and how do we apply them to the actual procedure that we're doing. Now, when we talk about audits, you brought up audits. I see practices get audited on the dental side, and they end up having to pay back a lot of money because their notes are not up to par and not showing medical necessity. Well, nobody really understands what medical necessity is because we've not been taught this in school. We've not been taught diagnostic coding in school, and they're still not teaching it in school. And when I ask dentists in school settings, in university settings, why are we not teaching this yet? They don't have a reason, and I know that their curriculum is so packed already, this is the last thing that they're ready to incorporate because it's not our first source of income. Our first source of income is going to dental, which is so limited and doesn't make sense anymore with where we're at in dentistry. So establishing medical necessity through diagnosis coding, that states the reason as to why we're doing the treatment we're doing. So diagnosis is the key. That's our golden ticket to everything. Without having a diagnostic code on a claim form to pair with a procedure, you're never going to get a claim paid. In fact, it'll reject. So one way to look up diagnostic coding, to make it very simple, there's this website, icd10data.com. And you can go to that. I will tell you, the more times that you look up codes, the more pop-ups you'll get for your favorite shopping places that come up as ads. But it's a great resource and it's free. As an example, if you look up severe atrophy, you're going to find this code. This is a CT of the maxilla, obviously, and you're going to see K08.26. That's the diagnostic code that would potentially go with a grafting procedure. And in this case, this was a very large grafting procedure, a couple different surgeries to add bone so that this patient could have a prosthesis even placed. If you look up at severe atrophy of the mandible, you're going to get K08.23. So it's just that simple of using actually the medical terminology of the situation and looking it up on icd10data.com. You could look up xerostomia, you could look up pain, jaw pain, and you're going to find all those codes in icd10data.com. We also need to start looking at systemic conditions. I mentioned cancer. This particular patient had pancreatic cancer along with other significant things. At the time of this photo, he was about 21. He wasn't expected to live past the age of 9, had finally gotten off of a feeding tube, and he had no posterior teeth to chew with. And we were able to get all of his crowns taken care of by placing a systemic condition as the reason as to why he was not able to function and what we needed to do to restore that patient to get full function back so he could chew. So systemic conditions are great opportunities. Cancer patients in particular, If they've had chemo or radiation, it bombs out the mouth. And we see patients all the time that we get treatment paid for in situations like that. Yep.
Kendra, I have another question, Roy Sonkin.
Kendra, what's the level of reimbursement and what is the limit on medical billing for this case? You got, I don't know, 14 crowns? What kind of
No,
reimbursement on the medical side?
They didn't do the anteriors at this time. That was done at Mayo Clinic, and the parents paid out of pocket for that.
All right, so you have 6 crowns.
Yeah, I want to say it was, I don't remember the exact amount. I want to say it was like $700 per crown is what we got paid.
This patient have dental insurance?
Yes.
Can you collect from both?
Yes.
Thank you.
Yes. Dental insurance and medical insurance are 2 different benefit plans, and that's why you're allowed to collect from both. You can't keep a penny more than what you charge, though. So that would be the only disclaimer there. You can't keep a penny more than what you charge the patient.
I have a question from Judy Oken.
Mhm.
Unmute, Judy.
Who do you give it back to? Do you give it back to the medical insurance or to the dental insurance
That
when you get
depends.
overpaid?
You pay who overpaid you last. Unless the patient paid you cash first, you would pay the patient back, and then you would repay the overage to whoever created it.
Okay, so say
So
you
if
get the dental insurance coverage first, and the patient pays the balance, and then you get the medical insurance. That means you're giving back the money from the medical insurance to the patient, and anything that's extra goes back to medical insurance?
Correct.
Okay.
Correct. Yep. Great question. Again, a claim is going to be denied if it has no diagnosis code on it. It will not be covered. We have to have diagnosis code in order to get paid. So it's important to know what that means. I want to talk quite a bit about evaluations because that's really where it all starts. We do an evaluation, whether it's in hygiene, whether it's in your doctor chair, whatever, the patient comes in. And it really starts with that evaluation and diagnosis. I know as a hygienist, it's really hard to not look at those teeth and want to try to clean all the calculus that's probably bridging them together. But we got to look beyond the teeth. We can't just look at teeth. In fact, with this patient, most of those teeth are non-restorable and going to be lost. So we need to look beyond the teeth and look around and see, what's going on here. I see pneumatization of the sinus. I see impaction. I see severe atrophy. There's lots of diagnoses that could go along with this patient. Key thing with evaluations in dentistry, we are paid a certain fee for, I'm just going to use an 0120. It doesn't matter if the patient is 80 years old or 8. We get paid the same amount no matter what. It doesn't matter that one was so much more complex than the other. We get paid so much. That's it. That's why it's a benefit plan. In medicine, we get paid to think. We get paid to think. And so we look at complexity. Does the patient have a lot of medical conditions that could alter our treatment plan or make it more complicated? We also get paid on time. So that changed actually this year. It used to be a little more complex than that. Now it's on complexity of the medical decision making, whether it's straightforward, low, moderate, or high, and the time. So it's very, very different. We're compensated on how complex the patient is and the amount of time that we spend with the patient, which I love. That's the way it should be. That's the way it should be. We shouldn't be in this box of not ever being able to charge more because